Florida Medical Association, helping physicians practice medicine.
Welcome to the Medicine Curated podcast. I'm your host, Tim Stapleton. The 2021 legislative session kicks off next week in Tallahassee. Throughout the months of January and February, legislators have been meeting in Tallahassee for committee weeks. Our FMA team, led by Chris Clark and Jeff Scott, have been working hard educating lawmakers on the issues impacting physicians and patients in Florida. And today, we're pleased to have the two of them join us to discuss what to expect during this year's legislative session. So we're going to start off with Chris. So Chris, tell us how the legislative process is a little different this year because of COVID. You know, what safety measures are being taken by the House and Senate?
It's going to be a completely different session than anything we've ever seen before. And we've experienced it through the last 5 committee weeks through January and February. But both the House and Senate have certain protocols. The Senate's are much more restrictive. There's no access to the Senate and to the Capitol side of the Senate side of the Capitol. And they're taking no testimony in committee. All testimony will be done down at the Leon County Civic Center, where you pre-register and you basically go and testify via Zoom. We've had a couple of doctors show up and testify that way. So it seems to work. It's just a very interesting process versus being in a committee room, watching the process and watching how things are playing out. The House is taking a little bit more lenient view. They're allowing you to schedule meetings with representatives, to where, a set time you're allowed in to go to your meeting and then you have to leave. Committee hearings, they're going to have invited guests in the committee hearings, and you can apply to reserve slots in committees. There'll be limited seating so they can socially distance. Everybody's going to wear a mask, and they're going to do that. So it's 2 different ways of going about it, but there's going to be a great deal of complications that come from this in the way of being able to lobby on bills and get information to members in a timely fashion. So it's going to be a challenge, and we're trying to put together a plan to minimize the difficulties and take advantage of some of the opportunities.
Yeah, I mean, obviously it's more important than ever to have those relationships with legislators, to be able to call them up, and probably more important this year than ever, because you're not going to have access to them inside the building. So I assume everybody, all the legislators and staff and everybody that's allowed inside the Capitol, they're all being tested every day, right?
They're being tested the first of the week. They're not testing them every day. They're testing them, coming in before they're allowed in the building to begin with.
Okay.
Again, while they're here, they're kind of coming and going. They're doing a lot of meetings outside the building at various places. We've had several members over to our downtown office. And again, it's a large conference room, so we can social distance and wear a mask. And so we've been able to have some of those meetings. But again, once we get into session and the pace picks up, it will be much harder to continue that.
So Jeff Scott, our general counsel, is the lead on some of our real important issues that we're dealing with this year. And one of those is medical liability protections for physicians who have treated COVID patients. I know there's 2 bills working their way through the process. One is focused on business liability, and the other is focused on healthcare liability. It includes physicians, hospitals, and nursing homes. So Jeff, tell us about the healthcare liability bill and update us on the status of that legislation.
Yeah, thanks, Tim. It's nice to do one of these podcasts with you. It's my first one, so I appreciate the invitation.
Well, we saved the best for last, right?
The FMA, we started laying the groundwork for the liability legislation back in September when we drafted a proposed bill that would protect physicians who kept their practice open during the pandemic. Our goal was to ensure that physicians who, they're provided reasonable protections from liability in 3 main categories. The first would be for those for patients who received in-office care who then contracted COVID. The second would be from decisions to postpone or proceed with care in light of a government-imposed ban on elective procedures. And the third would be from cases in which care was impacted by a lack of resources, whether staffing, PPE, or some other lack of supplies. And we worked closely with a number of groups, such as the Florida Hospital Association, Safety Nets, the dentists, to come up with one bill that would cover both the insurance, the business community, as well as the healthcare providers. And Unfortunately, the legislature felt that the best approach was to have two separate bills, and they started with the business community first. SB 72, it moved quickly through its first committee, while the House version, HB 7, passed all of its committees and is heading for second reading on the House floor. So, business liability moved very quickly. The healthcare bills, they took a lot longer to develop. They were in drafting for quite a while, and the FMA used that time to work behind the scenes with the House staff, with the members, with the governor's office, to come up with a good product that really protected physicians. And the final bills, they're out now, and they differ in their details, but they both share the same underlying construct. Senate Bill 74, which is the Senate Healthcare Liability Bill, would change the standard of proof in a COVID-19 related claim against any healthcare provider, changing the current ordinary negligence standard to a gross negligence intentional misconduct standard, which is a much higher burden to prove. This bill, the Senate bill, would also confer immunity from liability for healthcare providers against a COVID-19 related claim if supplies, materials, equipment were not readily available or were not available at a reasonable cost. The Senate bill, it's passed out of its first committee, and it's got two stops left before it heads to the Senate floor. The House bill, HB 7005, splits COVID-related claims against healthcare providers into two different silos. First, COVID-19 medical claims, and then COVID-19 negligent claims. And if you have questions about the differences between these two, contact me directly. It would take me a little while to go through that here, so I'm not going to get into the details. Basically, a medical claim would be like a regular medical malpractice claim against a provider for the standard of care violation, whereas the negligence claim would be more like something that you had a patient or a visitor come to your office and contract COVID and sue you, not for your medical care that they provided, but just sue you because they caught something in your office. For COVID-19 related medical claims, and these are going to be the ones that physicians will face most often, the bill provides that it's an affirmative defense to liability that the healthcare provider complied with all of the government issued health standards or guidances, and it further provides that a healthcare provider is not liable unless their alleged act or omission constitutes gross negligence, recklessness, or intentional misconduct. Close to what the Senate bill does, but just a little bit different. COVID-related 19 negligence claims would be handled differently. These claims would require a physician affidavit. There would be a preliminary hearing involved. There would be an opportunity to cut the claim off at an initial stage, and a determination would be made whether the healthcare provider substantially complied in good faith with the directives. If they did, the suit's cut off. If there would be immunity from suit. If they didn't, then the case could move forward, but the plaintiff would have to prove gross negligence by clear and convincing evidence. And that's a higher standard than a regular negligence claim. So, the House bill, it's been introduced as a proposed committee bill by the Health and Human Services Committee. It's not yet received its committee references. And both of these bills, they have some things that we'd like to change, and we've been in touch with the staff to make several, small changes to the bill language, and hopefully we'll find something that they can combine into one bill and pass both chambers.
Well, I know we've been working as part of a coalition advocating for these important measures. Tell me, what has been the reaction from the governor's office on these issues? As the governor, has he been supportive?
The governor has indicated that he's very supportive of both healthcare and business liability, and all indications are, if these bills, pass out of the chamber, that he will certainly sign them into law. So we appreciate the support that he's given, and hopefully he'll weigh in forcefully at the near the end of session when the two need to be combined if they're to get out and be.
Well, that's good to hear. So, Chris, let me ask you this. We've seen a big increase in the use of telemedicine during COVID. what are we doing this legislative session with regard to telemedicine? I'm sure that's an issue, right?
It is. It is. It's a huge issue, and we've got such a unique opportunity to push forward on it with what we've seen with telehealth, the use of it exploding last year because of the pandemic. But really, the other underlying piece that's driven it to being used so prevalently is the Medicaid and Medicare were paying in-office rates for people to use telehealth, and the private insurance companies followed suit and were paying for in-office visits via telehealth. And so, again, that's driving a lot of the usage. And we're already starting to see them moving away from that, of starting to pay a little bit less, or in some cases, considerably less for telehealth visits versus in-office visits. And truly, the patient ends up being the one that loses in that scenario. And so we've got a bill that we're working on that deals with payment parity and telehealth. We're working with the other providers and the hospitals to try to get that bill moving this year. And it may be a little early for us to push forward with it, coming on the heels of the pandemic. But I think we have to take advantage of this opportunity to move forward. But also, if the private insurance companies are not going to pay a fairer rate, we're going to see the use of it drop once life gets back to normal. So we feel like it's a good opportunity to push forward into it and to highlight that the providers should be paid the same for what they do via telehealth as they do in office, because it basically takes about the same amount of time for a physician to do that service. Again, it goes back to the patient's really the one that wins with the use of telehealth.
Yeah, and patients like it. It seems to be convenient. Most physicians' offices have expanded their services to provide for telehealth visits. So it's a win-win for everybody. And I think that hopefully the legislature sees the wisdom of enacting some of these, making some of these changes permanent, so that telemedicine can continue to increase. So, what are some of the other issues that other bills that we're working on to help our physicians proactively? I know we're proposing several insurance reforms. Can you tell us a little bit about those?
Yeah, we've got our step therapy bill that would allow physicians to override some of the step therapy protocols that are put in place. It's a bill that we've run for a number of years, and whenever it gets a hearing, very few people will vote against the bill, just because again they see that it's just a terrible practice. We've got a retroactive denial bill that would make not allow the insurance companies to retroactively deny claims that they've already approved. We've got a prior authorization bill to get a little more transparency in the prior authorization process, to help the physicians know what they need to do and how they need to go about doing it, but also force the insurance companies to come back with an answer so they can't just stall out the process. So we've got that. And then we've got another bill that's dealing with access to stage 4 cancer drugs. It's a very narrowly focused step therapy type protocol, but we worked on that issue. And then also there's been some clear bagging issues in the process of how the insurance companies are having chemo drugs given to patients. And so that was another one that we've got in the hopper this year. And then another one that's not insurance related, but it's more pandemic related, is access to PPE. And working with the Department of Emergency Management to kind of put some things, to codify some of their current practices and preparedness, to have them, research, what storage of PPE equipment is available, and also to kind of go ahead and start contracts to have those in place in a case of an emergency that the state can trigger to allow physicians and hospitals to access PPE. So that's another bill that we're working on this session.
Great. Well, that's a lot. I know there's another issue, Jeff, that you're working on. Last year, the legislature passed legislation regarding pelvic exams. That's proven to be somewhat problematic. So what are the changes that we're seeking this year to really fix that issue?
Any FMA member who even looks at a patient's pelvic area knows this legislation from last year has posed a significant number of problems and an avalanche of questions. The bill, which was Senate Bill 698 from last year, provides that a healthcare provider, a medical student, or any other student receiving training as a healthcare provider may not perform a pelvic examination on a patient without the written consent of the patient or the patient's legal representative, executed specific to and expressly identifying the pelvic examination. What does that mean? The uproar that we received from this was immediate, and the questions that they generated, we haven't been able to answer. So, the list is legion. What is a pelvic examination? Does this law apply to male patients? Does it apply to diagnostic procedures such as ultrasounds? Does it apply to procedures such as colonoscopies that touch the pelvic area? Does it apply to surgeries on the pelvic area? Does it apply to a visual examination in which the pelvic area is not physically touched? Does it apply when you have to touch the pelvic area to do a procedure on a non-pelvic area? The questions, were numerous, and we received a little bit of guidance from the Board of Medicine in a petition for declaratory statement that we filed. That's non-binding. It just gives you a rough guidance of how the board is going to interpret that. The Department of Health didn't give us much of any guidance on how to interpret these. So what we did was, over the summer, we worked with groups to come up with legislation that would fix the problems, answer all the questions. And fortunately, this last year's bill sponsors have been cooperative, and they've agreed to file glitch legislation, Senate Bill 716 and House Bill 361, to fix these problems. And this bill would change the definition of pelvic examination to specifically target an examination of the organs of the female internal reproductive system and require consent only from an anesthetized or unconscious patient. And that takes care of a whole lot of problems. Doesn't apply to male patients. You don't have the situation where, I'm going to check for diaper rash. Do I have to get consent there? It's on an anesthetized or unconscious patient only. It significantly narrows the scope of the legislation. And the bill would also exempt from the consent requirement a pelvic exam that's necessary for the provision of emergency services and care, and a pelvic exam that's indicated in the standard of care for a procedure to which consent has already been given. So that's going to cut down on a lot of the questions as well as the instances in which you've got to get this consent. And furthermore, the bill would provide that written consent it may be obtained as a part of a general consent form, and that one written consent may be used to authorize multiple healthcare providers or students to perform an exam. So those are the major changes. There are a few others that I know some folks would like to have, and we're going to work on seeing if we can get those included in the final product.
Well, that's great. Thanks for that update, Jeff. I know, oftentimes there are measures that pass the legislature that might be well-meaning, but unless you're a physician, you don't understand the impact that has on the practice of medicine. And fortunately, we had a number of physicians contact us. We were able to get in touch with the bill sponsors. Unfortunately, we couldn't change what passed last year, but we're working to get it fixed this year. And again, that's just an example of the value of staying engaged in the process, having physicians working with us, really letting legislators and policymakers know how these things affect real life practice of medicine. So thank you for your work on that. Now, Chris, every year there are always a plethora of bills that seek to expand scope of practice for non-physicians, essentially allowing mid-level healthcare professionals to practice medicine without going to medical school or even completing residency training. And we deal with these every year. Last year some of those got some traction, and we spend a great deal of political capital every year fighting these measures. So, what scope of practice issues and bills are there this year that we're actively opposing? And I know there's a bunch of them. So kind of if you could run down the list of scope of practice issues that the FMA is opposed to this year.
Sure. Yeah, it's an issue that just is playing whack-a-mole, and it comes back every year. But this year, there's a APRN autonomous practice bill that basically would allow the APRNs to specialize in dermatology, ENT. They would basically be able to pick their specialty and practice autonomously without any supervision from a physician. And so it's a bill that we've got major problems with, and we're working with a lot of the specialty societies to bottle that one up and kind of beat it back.
Does that include nurse anesthetists as well?
Yes, it includes all specialties, every single one of them. If that's what the nurse is trained in, they can practice autonomously in that specialty.
How do you define training in that instance? I mean, someone just says, "Hey, I specialize in dermatology, and so I'm a nurse dermatologist." Is that how it's defined under this bill?
Yes, it actually piggybacks on the independent practice bill that passed last year, where basically that bill limited it to only primary care. This removes that limitation to primary care. So it has, I think, 1,200 or 1,600 hours of additional training, but really very little more than what they required last year in the independent practice bill. So it's a terrible bill, and like I said, we're engaged with several of the specialties working on that one. And again, the good news is it's got everybody working together against it versus just having one or two specialties engaged in fighting it.
Mm-hmm. What else? What other scope issues?
Another bill, last year the physician assistants were taken out of the independent practice bill. There's a bill this year that would include them into it. And again, you know, there was a lot of arguments made about the lack of training for physician assistants and why they were taken out of the bill last year. So I'm hoping we're going to work on that and pick up where that left off last year and making sure that we can stop this bill.
So that would allow physician assistants, and their title is physician assistants. So, you know, that title is pretty self-descriptive. They're there to work with and assist physicians. This would allow them to practice without a physician. So you'd have physician assistants. Basically, they would be able to function as physicians.
Autonomous physician assistants.
Interesting.
I don't know how that works, but yeah, that's what they're doing. So that's one that we're going to be working against this year. Another really egregious bill is an optometry bill that would basically allow optometrists to become fully practicing ophthalmologists. It allows them LASIK surgery, full prescribing authority. It gives them everything that they need to basically practice ophthalmology without near the training. And, I think only 3 other states allow this. There's some good studies that show that in the states that allow it, where the optometrists have done some procedures, that they've had to spend a lot of money to kind of come back in and fix some of those. So again, it's pretty scary stuff. And even if you look at like Oklahoma, a state that allows this, it's only a 14-hour training course that the optometrist has to take before they can be a fully practicing ophthalmologist. So this one is a really bad bill, and we're working with the Florida Society of Ophthalmology to stop this bill. But again, it's a pretty egregious bill. And then the last, well, not the last one, but another big one that we're working on is a bill that would allow psychologists prescribing authority. And this is one we're working with a psychiatrist to stop this bill. And this is just as egregious also.
When you say prescribing authority, it would allow them to like prescribe psychotropic drugs. Is that
everything?
Okay.
So that's another one that we've got there. And then there's a couple other issues with the audiologist where they're trying to sneak a little scope expansion through in a bill. And so we're just having to watch and track all of those bills to see where anything pops up.
All right. Well, that's a lot. I think clearly the fact that the FMA is there in Tallahassee, keeping an eye on all this, working, educating lawmakers every day on the dangers of scope of practice expansion. Hopefully that is having an impact. Obviously, what's the point in going to medical school if you can just practice medicine without having residency training or having to do all the things that physicians do? Certainly that's bad for patients. We know that. And I appreciate the work that you guys are doing in educating lawmakers on those issues. And hopefully, some of the proactive measures that we're pushing, we can see those move along. Obviously, the liability issues are important to physicians, changes to telemedicine, and anything we can do to improve the practice environment for physicians relative to, the hassle factor and dealing with insurance companies. That's all very important. So I want to thank you guys for joining me today. Just so our members know, we'll be updating you throughout the legislative session, probably on a weekly basis. But certainly, as things move along, we'll be providing updates to you. So stay tuned. And again, guys, rest up, take your vitamins this week, because I know at the beginning of session next week, you're going to be working long days and long hours on behalf of our members. And, we really appreciate what you do.
Thanks, Tim.
Absolutely.
All right.
Thanks.
Thank you. All right.
Florida Medical Association, helping physicians practice medicine.